On Viewpoint this Monday afternoon, we delve into the incoming administration's planned COVID-19 response framework, as well as the Biden administration's ongoing efforts against the pandemic. For that purpose, I have Professor Jung Ki-suck from Hallym University. He's also on the Presidential Transition Team's COVID-19 Response Committee. Professor Jung, it's been a while and it's a pleasure to have you back.
My pleasure to be here again.
I also have Professor Peter Chin-hong at the University of California, San Francisco, live on the line. Professor Chin-hong, again, it's a pleasure to have you too.
Thanks for having me back on, Sunny.
Right, Professor Chung, we'll start here then. The Presidential Transition Team has unveiled a 100-day roadmap to respond to COVID-19 upon the launch of the new administration on May 10th. Could you tell us a bit more about the gist of this roadmap?
Well, it has four major pillars and 34 specific targets. The first one is the science-based quarantine policy. It's like evidence-based medicine. So we need data, a big data. And antibody level, as you already know, we are going to check antibody level in about 10,000 population. And the integration of all information system is needed because we don't know, we know that who are vaccinated, we know that who are admitted, but there is no integration between the system. So we are going to make that kind of a system. And the second one is a sustainable infectious disease response system. So far, the healthcare center belonging to a local government has been managing all the patients. It's not sustainable because we have far more clinics and hospitals in the neighborhood. So we are going to make all those clinics participating in this coming pandemic. And also the emergency room system and ICU system will be more organized, and nobody can be in the waiting list for admitting to ICUs. And the third one is intensive protection of high-risk population facilities. As you know, the high-risk population, immune-compromised, elderly people, those people has been dying due to COVID-19 because of a bit late treatment, late diagnosis. So we are going to make a fast track for them. So early diagnosis, early administration of antiviral pills will make them the fatality very low. So that's the third one. The final one is in the vaccines, antiviral agent. So we are going to secure more secure supply of vaccines, antiviral agent, and also there are some people who have been hurted by vaccination, adverse event. So there will be a sufficient compensation for them.
Right, I see. Professor Chin-hong, in early March, the Biden administration shared its own new strategy against the pandemic, the National COVID-19 Preparedness Plan, I believe. Now, I understand the strategy has 4 objectives. Could you briefly share them with us?
Yes, Sunny. So the overall strategy is really one of prevention, and not only domestically, but also with an eye towards the world as well. And these 4 objectives, I think of them as the 4 Ps, are prevention and treatment in general, and that includes also a test and treat strategy around Paxlovid, the oral medication for COVID, or early COVID. As well, there is also some thinking around research into long COVID. The second P, of course, is preparing for new variants, and that includes looking at wastewater, also some thinking around new vaccines and combining different variants for the next generation of vaccines. The third is preventing economic and shutdowns in schools. And what that includes also is, interestingly, ventilation in schools that's going to be upgraded, as well as strategies like giving money to workers who get taken out of the workforce because they are infected. And finally, the 4th strategy, the 4th P, has an eye towards the world, and that is continuing to think about providing actual vaccines as well as funding to produce vaccines into the arms, to make sure they get into the arms of people, not just in the US, but around the world. So more than 1 billion vaccines have been promised. But of course, all of this takes money, and right now, that discussion is in the Congress. It will take at least $10 billion to effect all of these 4 Ps.
Right. Professor Chin-hong, top U.S. infectious disease expert Dr. Anthony Fauci says the U.S. has transitioned into a controlled phase of the pandemic. What do you suppose he means? I mean, does this mean that the US is a step closer, perhaps, to declaring an endemic phase of this disease? And speaking of that, what prerequisites, Professor Chin-Hong, would be necessary to make such a declaration, do you think?
Well, Sunny, Dr. Fauci initially got some heat because of the verb he used. He said transitioned into more of a controlled phase, and I think many people were thinking it should have been a gerund, which is transitioning. So I think what he was talking about was the fact that we went from 3,000 deaths a day to about 300 now. There are new agents like Paxlovid, there are new tools in the toolkit. But I think that the difference is, and the reason why we're not necessarily in an endemic phase, is that endemicity requires predictability. And the only thing predictable about COVID is that it's unpredictable. So even though these flavors of Omicron, BA1, BA2, BA4 and 5 now from South Africa are very, very similar, and we have a large amount of immunity, a big immunity force field in the country right now. Take the fall or the winter in the United States, there may be a new variant, and it may not be the same.
Right, I see. Meanwhile, back here in the country, Professor Chung, authorities have lifted the outdoor face mask requirement as of this Monday, but the Presidential Transition Committee had spoken about making a decision on the fate of outdoor face masks in late May. How does this latest decision by the current administration look to affect plans by the new administration?
Well, it's a kind of a small conflict between two bodies. I think it's about time to take up masks outdoor. Right? But if you look at the daily tallies and current situation in Korea, it's not stable. So the daily tally is still tens of thousands patients, and there are quite many ICU patients still remaining and still occurring every day. And even though the government is banning gathering of 50 or more people without taking masks, but there are some concerns about high-risk people, and also some concerns of very close get-together within 2 meters and eating and chatting for quite a long time. Then you can easily transmit. If you have anyone has a virus in their mouth, then you can easily be transmitted. So I suggest, as a member of a committee, made a target to the current government and say, let's say, in order to do that, you must halve the mortality. Current case fatality is about 0.1%. If you can halve the case fatality, like 0.05%, that's good. And if you keep daily tally below 50,000 every day, it's almost 50,000 weekly average, but then we'll be more secure to take up all the masks in our outdoors. Because the early lifting may delay the decreasing tendency of current circulating virus, and the accumulation of those viruses in our society then make a fuel to a winter resurgence. So I don't like to see many viruses circulating in our society until the entrance of autumn. That's not a good sign.
Right, it isn't.
Yeah.
And staying with masks, in the US, Professor Chin-Hong, face masks continue to fuel much dispute. I mean, some pundits there have said the removal of federal and public transportation masking reflects the rising reliance on informed decisions by members of the public with regard to COVID-19 prevention. What are your thoughts on this trend?
Well, I think a lot of us were astonished when this was overturned by a federal judge from Florida. And the reason why I think we were a little bit nervous is because there are 4 groups still at risk for getting seriously ill. Of course, many people already have immunity. The CDC estimated that more than 60% of Americans have seen COVID already. But nevertheless, not everybody has. And our infections are still rising by about 50% compared to the last 2 weeks. Although deaths are still going down, hospitalizations are still going down. And of course, the 4 groups are those who are over 65 and unboosted, those who are immune compromised, those who are unvaccinated and never exposed, and those who live with any of these groups. So I think it just involves people wearing better masks. So I think on the plane with good ventilation, it's okay. But in public transit, like buses and trains, you have people from all different walks of life. They may not be able to have the best quality masks. So I think in some cities like San Francisco, that has been overturned again, and now masks have been reinstated on public transit, also in Los Angeles.
Right, I see. Good to know. Professor Jung, as you mentioned earlier, the new incoming administration will launch a nationwide antibody testing. Could you tell us about the purpose of testing on the prevalence of COVID-19?
Well, before I say that, antibody is not the same one. Some antibody can detect both infected and vaccinated, and some antibody can only detect the infected one. So we knew both sides, the level of antibody. And the reason why we are going to know the proportion of infected population, just like Professor Jung said, US said that 60% or more has been infected. So we do not know how much percent of our population has got already infected, even though we have about 15 million people over is infected. But I guess maybe half of our population has been already infected. So that's very important because the U.S. said that they have 60 and over percent of infected, and they are going to go to endemic. If you have, say, 80% of infected person, then we do not need to keep social distancing. We do not need to much focus on the vaccinating fourth shot, fifth shot, and etc. So that's why we are going to check antibody level. And on top of that, the concentration antibody in each individual and the durability of antibody in each individual is very important. That is the main factor to determine whether to put the second or third shot in specific person. That we know that it lasts only 2 months, and in some persons it lasts 6 months, and so on. Infected person, the antibody lasts 8 months, and so on. So we need to know the scientific basis to make a more accurate policy on the vaccination schedule.
Right. And staying with the booster information that Professor Chung has just mentioned, Professor Chin, I hear that the question of how many booster shots are needed remains a very much open question, especially in light of data from Israel that found the second booster's effectiveness fell just a month after vaccination. Where do you stand on the debate over second booster doses?
Well, Sunny, it depends on what your goalpost is. If your goalpost is prevention of infection only, of course, no matter how many boosters you get, if the variant or subvariant looks very different, it may not prevent infection. However, our T cells and B cells that have memory are adaptive. They change with the enemy. And that comes back to that second goal, which is prevention of serious disease, hospitalization, and death. Now, the second booster isn't generally as beneficial in everyone. So the older you are, the better it is. If you look at the European Union, they are saying that we'll give it to folks over the age of 80. In the US, it's approved for those over 50, but the older you are, the better it is. So how do I think about it? I certainly don't think you have to run out to get the second booster. Maybe you can walk out to get it if you're eligible, and you walk a little bit faster the older you are. I think that it's very difficult otherwise, and if we protect our most vulnerable population with the second booster, that's important. And the last point is there's still tens of millions of Americans who haven't got the first booster, and the first booster is unquestionably really, really crucial to prevention long-term of serious disease, hospitalization, and death.
Right, of course. And finally, one final question to Professor Jung before we end. I think we have about a minute. On the treatment front, Professor Jung, within 50 days of its launch, the new administration has spoken of boosting the role of local clinics, as you mentioned earlier. Could you tell us a bit about that?
Well, it has been administered by a Korean government with the healthcare center so far. But as I said before, we have many doctors who have quite many experiences, and nurses all together ready for our patients. So patients are very convenient when they can visit neighboring hospitals and clinics, and doctors are ready to diagnose and treat COVID-19. So next surge, as many doctors as possible, maybe more than 30,000 clinics up and down the country can participate in the diagnosis and treatment. Then we can treat COVID-19 as endemic disease, such as we are treating influenza exactly in Korea, taking care of influenza by GPs and some specialists and neighboring hospital. And the primary, secondary, tertiary hospital transport system will be more organized, and we'll have a more sophisticated emergency room care and ICU care. Then will be quite safe in coming next COVID-19 research.
Right, hopefully. Professor Jung, as always, thank you very much for your time and your thoughts today. And Professor Chin Hong over in the US, thank you very much for being live with us at this hour with your insights.
Thanks so much, Sunny.